Thank you, Chairman. My brief is again to jump back to the arthroplastic options. The brief given to me is about some changes in the hemiarthroplasty. This is some procedure which all of us in the room have been performed to fair numbers. If you look broadly, trauma still probably remains as the main predominant indication, though there are reports in literature regarding indications in ischemic necrosis and osteoarthritis. But if you look at the results, published data, they fall nowhere near the total hip arthroplasty. I think it's without debate that in the other indications, probably total hip replacement scores as compared to the hemiarthroplastic situations. But again, coming back to the trauma in the elderly, I think there's always a controversy and a flip-flap as what is appropriate. Should we do a hemi, should we do a total, or should a fixation? And what is the sort of a long-term outcome and the morbidity, mortality issues associated with this? Looking back into the hemiarthroplasties, which normally now have a 50-year data or 5-decade data, most of the early failures in the hemiarthroplasties were metallurgical failures and fixation failures. More often, these were monoblock devices and suboptimal in terms of restoration of the hip mechanics and the kinematics as we understand today. The second most important group of the sub-cause of failure was the cartilage failure over a period of time when some of these good cases started deteriorating over a 5 to 8 year or a 10-year period. Suffice to say that the fixation issue today, mostly the reason was basically these were non-integrating surfaces when they were used as the uncemented devices, or the sharp corners in the cemented devices led to a cement breakdown and the failure. And what we perceived as the bone ingrowth through these macro holes never really consistently occurred. And so essentially it was a poor design of both the cemented and the uncemented variety that led to the early failures. And the limit success in the medium and the long term being limited also by the stem failure in terms of sizing, seating, poor offset, and of course over the long term the cartilage erosion and pain. And that's one reason why if you see multiple results showing inconsistent good results. As we understand today, I think the design and the fixation issues are more or less rested, because if you use the modern designs of the cemented and the uncemented variety, I think adhering to the proper cementation techniques, I think we score. And so this is not an issue anymore. And more importantly, the possibility of having a modular design both in the unipolar and the bipolar hemis would probably improve the results today. Proper cementation, as we all know, I think has given a good stead in that the 10 to 12 year results. If you have a type A cementation, the possibility of a loosening is much, much less. Second important problem we face both with the unipolar and bipolar is a mismatch between the acetabular articular surface and the prosthetic surface. They are never coapting hemispherical like we have the large ball things. Another important why the cartilage fails in the earlier term, in this case, the large metal to a cartilage interface is the age and the activity level, the sizing, and the surface contact patterns are quite varied when you look at it broadly. Looking at the literature in the unipolar designs, the cartilage tend to fail. The erosion and the protrusio seems to be directly correlated with the age at which we put and the level of activity. And in the symptomatic group, there's a 40% incidence of revision over a 5 to 8 year period of time. So the cartilage failure seems to be predetermined depending upon the level of activity. And at 5 to 6 years, if you look, there's a near complete loss of the acetabular cartilage. That makes it more symptomatic. And if you look at a matched group of people with normal cartilage at the time of the surgery, the rate of wear of the cartilage in the non-implanted is much slower as compared to the prosthetics. There are some who also looked at the histology of the cartilage of the replaced fibrous tissue. And at 6 years, when you do it during the time of the revision, they are more or less completely replaced with the fibrous and the scar tissues. This is what is again seen with the progressive radiological migration and the protrusion that starts happening. And again, the histological studies which are performed at the time of the revision alluded to the fact that the cartilage destruction to almost no cartilage happens. And this leads to a 37 to 40% incidence of revision reported by multiple authors at a 5 to 8 years. To overcome this, there has been some advocacy to pre-ream the cartilage, trying to substitute the cartilage primarily and get a better coaptation of the surface by substituting And maybe if you have a bipolar design, probably it may remain easy to convert. But the earlier designs failed again in this case basically because they were the concentric design. Both the outer cup and the inner cup have a single center of rotation. And so they were deficient in the fact that these cups tend to migrate into the varus, and that led to the sort of impingement medially, and that led to an accelerated wear of the polyethylene, subsequent fracture and dislocations. So the newer sort of bipolar designs across the various manufacturers today we have are this eccentric offset. This leads to probably a sort of a deeper penetration of the head in. So that gives a better containment, and this also helps in the self-centering concept. As you start moving, the hip comes into the line of weight bearing. That uniformly further distributes the stresses, and this sort of self-adjusts over a period of time. And this is at the end of 2 years you feel it adjusts. And the idea which you want to have, so that will decrease the point loading and the lesser of the cartilage failure. The primary articulation, if you look at and you do the in vitro studies, is that and low load, both articulations work well, but at the higher loads, it's the outer one that works. And the loss of cartilage, if that is happened, it sort of gets fixed, and it is predominantly inner load bearing, which is what is wanted. So there's sort of this eccentric point leads to sort of eccentric and generates a valgus force, which is what is probably wanted. And this sort of a self-centering mechanism works and depends a lot upon the applied load in a very heavy person maybe, and in the condition of the diseased cartilage. In trauma, probably this is just beneficial because most of the traumatic cases we have a normal cartilage. The question finally that remains to be answered is this dual motion retained? It is found that at earlier times it is predominantly inner bearing motions in vitro studies, but at 1 year it seems to depend upon whether the cartilage is normal or degenerate. In the normal cartilage, I think we have a bipolar motion that gets preserved, but in a degenerated case or in osteoarthritic situation, probably you will not have this. And this dual motion also appears to decrease over a time. Head size doesn't seem to have a bearing. There is a flip-flop, but it appears like it does not have a huge bearing, whether you use a 22, 28, or a 32 head size in the bipolar designs. So this self-centering aspect would be effective in trauma and in the initial years, but as the time goes by, probably you get less and less of this. But we need to understand only a few complications of the bipolar. That is basically sometimes you may end up if you have a component dissociation, or again a concern of impingement if it does not. And that seems to be one fact and one aspect, because when you have this, you also have a eccentric polywear, considerable polywear, which has been published by Harry Rubash, and this may be a model form of failure. 10-year results today, if you look at the bipolars, I think it is encouraging. I think it's about 80-85% results. And if you look at finally the unipolar versus the bipolar, I think the pendulum probably swings a little more towards the bipolar side in terms of lesser failure rate and a better functional score. And this seems to be a little more with this. So finally, hemiarthroplasty today, I think what is important here is treat it like a hip, prepare your femur like a hip, cement or uncemented like a regular hip, what we do. And more importantly, choose the right patient, preferably a low demand and a very elderly patient. In all the other cases, probably you are talking of only a 80% result at about 5 to 8 years. You are probably appropriate in using the smaller approaches, better capsular repair so that we do not have a problem of dislocation, preserve the labrum because that will again further augment the cover, and critical attention to the sizing of the prosthesis. Steps like total hip, like I said, cemented or uncemented depends basically upon the general condition, and modularity has been a great boon in the modern hemiarthroplasty. The controversy regarding unipolar or bipolar continues probably, but they're better designed with a better poly, adhering to the steps probably would ensure a fairly good outcome in the newer design of the hemiarthroplasties. Thank you.